AACCI only.
Acha. So through
Yeah.
your mobile. Okay.
Yeah, join with mobile on.
Yeah, so we are live on YouTube. Samirba, you want to start or should I start?
No, you will.
Okay. So, good evening, everyone. On behalf of AACCI, I, Dr. Prashant Karya, a National Youth Forum in charge, welcome one and all to today's international webinar, which is Introduction to Genetics and Counseling. I request Director and CEO Dr. Swati Bhave for her welcome remarks.
Thank you, Prashant. I welcome our chairperson, Dr. D.E. Gradanis from USA, and our star speaker today, Shibani Kanugo from USA, and Prashant will be giving her credentials and introducing her. I also welcome Dr. Samir Shah, our national coordinator, and Dr. Kamlakar Devghare, our AACCI Vidarbha Region Grandparenting Forum. Samir, you can take this. This is a very, very important topic, both for all, especially pediatricians and clinicians, when we should do genetic counseling, when we should wait, when to refer a patient, what sort of patient will benefit from genetic counseling. And Shibani, being an expert, take us through this journey of understanding when, how, where to do genetic counseling. Over to you, Prashant.
Thank you so much, ma'am. So without taking much of a time, I would like to invite today's esteemed speaker, Dr. Shibani Kanungo. Dr. Shibani Kanungo, ma'am, she is an accomplished expert in the field of pediatrics, genetics, and public health. She holds a prestigious degree of board certified American Board of Medical Genetics and American Board of Pediatrics. And her academic journey includes a postdoctoral fellowship at the University of Pittsburgh and a subspecialty fellowships also. She specializes in the medical biochemical genetics, and she holds masters in public health also, with focus mainly on the maternal and child health from the University of Illinois at the Chicago. She's also a renowned author of Rudolph's Pediatrics 23 and 24A and multiple peer-reviewed journals. And she stands as a dedicated advocate for maternal and child health, impacting lives through her exceptional clinical and academic contributions, mainly through the genetics. And without taking much of a time, I invite ma'am for her talk. Welcome, ma'am.
Thank you, Dr. Bhave. You've always been an inspiration, whether it was 30 years ago in Bombay Hospital or even today. I always aspired to be as energetic and as involved in the field as you are. And I am extremely honored to provide this topic near and dear to my heart. And that is Introduction to Genetics and Counseling. We will be providing an overview without getting much into the technical aspects of genetics, but we will focus mostly on counseling from a clinical standpoint. What are the nuances we need to be aware of? I have no conflict of interest to provide this talk, and I welcome any feedback on this talk and interest from AACCI members and whoever is going to join this talk. Thank you. So the objective of this talk was to just understand some key basic genetic concepts. We'll talk about gene, genome, chromosome. What do you mean by variation? How is that different from mutation? What are inborn errors or metabolism? That's also a subset of genetics. We are going to dive a little deeper into inheritance and a very informational and helpful tool, which I'm hoping everyone and the younger learners today can adapt to, is the pedigree analysis. We will hit on genetic testing, counseling pieces, and discuss case vignettes in ethical paradigm. So talking about genes or genetics, we just have to go back to our middle school or high school cell biology, and we have to remember, and this is just kind of like touching back on some of the elements that we know of a cell. is just like a human body. It has a central core, the nucleus, where all the genetic materials are there. And there are other compartments in the cell that are useful for cellular metabolism. So the central component of the cell, the nucleus, is where all the DNA or the genetic material is stored, but that's not the only place where DNA or genetic material is stored. Mitochondria, which is the energy subunit of the cell, it's almost like lungs. It provides the energy, the electronic transport chain and respiratory chain complexes in mitochondria is that kind of helps the cell survive. So the mitochondria is unique in its own aspect and has mitochondrial DNA too. So the nucleus has nuclear DNA and the mitochondria has mitochondrial DNA. And we will get back to this later in the lecture too. So how is the genetic material stored in the nucleus? The genetic material stored in the nucleus is in form of chromosomes. So what are chromosomes and how is that important? We have to know that we all have 23 pairs of chromosomes. Of those, 22 are called autosomes, and the 23rd pair is the sex chromosome. So sex chromosome could be XY if you're a male, it could be XX if you're a female, but we have to remember that we get one copy of the chromosome from each of our parents. So the 22 pairs of autosomes, each of them, one copy comes from dad, one copy comes from mom. Similarly, the sex chromosome. So when, males are XY, so when when you inherit X chromosome from dad, of course, your mom just provides the X. So then the offspring is a female, and when Y is provided, the offspring is male. So chromosomes on itself is X-like structure, and each of the set is called chromatid. It has a central centromere, and there is the short arm and the long arm, the P and Q. The ends are called telomeres, but when you stretch the chromosome, it's kind of like a twisted ribbon. And when you stretch it furthermore, they are kind of seems like there are like beads around which a thread is kind of put together. And that is a nucleosome or the histone complex around which the chromosome is tightened. And all these are important in cell division, and we will touch upon these in future lectures. So when you get the DNA material kind of stretched out a little bit, then you see the double helix. And double helix has kind of two components, if you may, to simplify it, or rather from macro, I'm going into micro view. So there are all these base pairs that are lined up. Now, base pairs are made of 4 amino acids, and those are ATGC. If you remember the movie Gattaca, that's what it's: cytosine, thymine, adenosine, and guanine. Now, these base pairs are almost like as if you are reading a book. The alphabet sequence has to make a sense. So when those alphabet sequence, whether it's a short alphabet sequence or long alphabet sequence, that's what makes up the gene. So these alphabet sequence, any time if there is a misspelling, and that's what we call variation. Now, variations is just another word for change. Earlier, the term mutation used to be used, but that kind of goes synonym to the variation being pathogenic or rather disease causing. So having said that, if we know that these are the 4 alphabets, A, T, G, C, and there are pairs of those, and there is, depending on the length of the gene, it could be a shorter gene. So any small changes could make a significant difference. Or if it's a longer gene, then smaller changes may not cause that much of a clinical difference. So how is genetic material kind of flows within the cell? It goes from DNA. DNA is pretty much kind of like slit, and then by RNA, and then the RNA pairs, and further DNA is made, which is then clumped into a polypeptide, which becomes a concrete protein. And that's what is the building blocks of a cell. And that's where from one fertilized egg, we become a whole human being. There is a lot of dynamic activity going on, and that doesn't stop from birth. It continues until we die, or even a little bit later. So the dynamism of this cellular interaction is lifelong. It's not only for growth, but it's also for regeneration and survival. So in short, genetics, it does not, it's not cellular level, because, our whole body has cells. So every cell and every organ system can be involved, and that's very important to know. Having said that, we will welcome to Michigan, the most beautiful place on earth, I would say. This is Pictured Rocks. Anyone visiting Michigan, please go to Upper Peninsula. Pictured Rock is somewhere out here. It's actually, those are the actual colors, so you can see how pretty it is. This is a lake which is 100 feet deep, and there are fishes which are like 20 feet long. So you can see the diversity. And this is, of course, Lake Michigan. That's Lake Superior. So Lake Superior is out here, Lake Michigan is out here. And these are the beautiful beaches, which is not on a salt water, it's on a sweet water. So that's what Michigan is. It's like a thumb with a... All righty. So moving on to talking about, probably in India, it's close to dinner time. So you are thinking about, what you're eating. So I would want you to kind of like always consciously think about the nutrient components of whatever you are eating. So definitely there are starches or carbohydrates. They come in different forms. There is fats, and oil, butter are most part of it, but there's also animal fat. So in proteins, there is meat, fish, and of course legumes, which is a big part of the Indian diet. So, and there are vitamins, or as we call it, cofactors. That's lots of fruits and vegetables that help in the whole metabolic process. So why am I talking about it? I'm talking about it because, anytime the breakdown of these are affected, that could also lead to a genetic subset of disorders called the inborn errors of metabolism. So inborn errors of metabolism or metabolic disorders are when protein, vitamins, carbs, or fats are not able to break down through biochemical pathway to provide the building blocks and energy for survival of the cell. So it can happen on a cellular level, and there are processes biochemical pathways that kind of connects the different major nutrients too, and that can cause also complex diseases. Having said that, how does that work? So, biochemical pathways go from substrate A to substrate B, and enzyme, as you all know, is a protein. And proteins, if we go back to the initial slides, it is kind of like, from proteins are made. And whenever there is enzyme defect, that's you start seeing signs and symptoms of errors. So if the enzyme deficiency can depend on the gene that codes the enzyme, kind of a variation is in that gene, whether there is a catastrophic, or as we call, a null mutation. That means there is a spelling change in the gene that kind of pretty much does not produce any protein, and that means there is no enzyme activity. So basically, like substrate A cannot get into substrate B. But if there is a milder change, then there is some enzyme activity, but those enzyme activity can cause milder versions of the disease presentation. But why is the enzyme not working? The enzyme is not working because of the gene defect, as we talked about, and that leads to accumulation of the substrate that cannot be metabolized into the subsequent substrate. So the accumulation of this and deficiency of this can both cause clinical presentations or clinical issues. Now, you need to correlate these to like a traffic light not working. So whenever there is a malfunctioning traffic light, the traffic tries to find other ways to find their way to get going to what they were doing. Similarly, the biochemical analytes find other ways, and that's how they come into bloodstreams and bodily fluids, including urine and cerebrospinal fluid. And that is what helps people like me, who's a biochemical geneticist, look at them for cues before we try to think about if a gene is working or not working. So biochemical pathways, it's actually kind of, this is a representation. It may be seem like, for electrical engineers, it may be looking like a circuit, but that's what human cell is. This is where proteins are metabolized. I think here is the basic starch metabolism because it's readily available. We all know our Krebs cycle from med school and we love it. Here's the energy metabolism or the respiratory chain, and here are some of the complex molecules. But it is kind of like, once we have this kind of understood basically where the problem is going on from clinical presentation, it's very easy to decipher. So metabolism, the carbohydrates, proteins, fats, vitamins, and cofactors. So proteins break down into amino acids, organic acids, urea, neurotransmitter, nucleic acids, glycoproteins. Carbohydrates break down into glucose, galactose, glycogen, fructose, lactose. We all know the lactate, pyruvate, and glycosaminoglycans. Fats break down into fatty acids, acylcarnitins, lipoproteins, bile acids, cholesterol, oxysterol, dolichol, sphingolipids. Vitamins are pyridoxine, thiamine, riboflavin, folate, and all vitamins and metals and minerals for that matter. What they all do, which is going back to our first slide, is they provide the energy for survival and they provide building blocks, that is for growth and for regeneration. I'm just going to briefly touch upon newborn screening because in the US, every new after 20 undergoes the heel prick or what you call it, the dried blood spot screening. And today's day, there are probably 36 core conditions and additional making up to 60 or so conditions. Most of them are inborn errors of metabolism, though there are some other genetic disorders, and there are some other non-genetic conditions like hearing loss, which may or may not be from a genetic or from prenatal exposures, or there can be also the congenital heart conditions. I wanted to touch upon talking about a little bit as we get closer to fall, and this is what fall colors look in Michigan. I wanted to touch upon a little bit on different fields of genetics. From training standpoint, you, at least in the US, you have to get certified into one of the primary care specialties, be it pediatrics, internal medicine, med-peds, or family medicine. And then you go on to getting into the medical genetics. They call it residency, which is 2 years, and then into subspecialty, which can be cytogenetics, molecular genetics, or biochemical genetics. And biochemical genetics has two aspects of it. One is the lab biochemical genetics, and another is the clinical biochemical genetics. Now, but in the practice of genetics, you can pretty much break it down from clinical genetics. You know, most of the time it is the prenatal genetics is practiced by OBGYN who are subspecialized in maternal and fetal medicine, go on to doing genetics subspecialty. So that's the prenatal genetics practice aspect. There is general genetics that whoever has done the 2 years of medical genetics practice as general genetics, that's basically trying to figure out which syndromes or conditions are there. And then there is biochemical genetics, which is pretty much going further on to looking at biochemical pathways. And there is an aspect called the cancer genetics, which few geneticists have started collaborating more so with the oncologists to provide the best counseling aspects. But genetic counselors have pretty much kind of subdivided themselves as either prenatal genetic counselor, cancer genetic counselor, or just general genetic counselors. So having said that, if our younger learners have a paper and pen, I would encourage you to just at the end of the lecture, draw your own family tree, because the pedigree piece and the family history is such an important aspect of trying to pinpoint what is going on, but more so from counseling standpoint. So the squares are males, the circles are females, and the lines that connect are called the relationship line. So in this instance, this is the male, that's the female partner, and that's the relationship line, and this is the descent line. That means how many offsprings are they having. And of course, that's a female, that's a male. This AFAB or AMAB is the assigned sex at birth. Okay, so that does not mean gender. I'm talking about assigned sex. And there can be, if it doesn't lead to a successful pregnancy, you can have other notations for that. So to make a pedigree, basically, you have to start with the patient that is presenting to you, and that is called the proband. So usually when I draw pedigrees, the patient coming to me is the first person that gets on the paper, be it a female, male, and then I put an arrow because that's your proband. And from there, I go on to seeing who's the mom, who's the dad, and their age. And on the sides, I start writing about their if they have any medical conditions or not. From mom and dad, I go on to getting each mom and dad's, the maternal and paternal grandparents, and any of the uncle aunts. So if the proband has siblings, then there is the descent line from mom and dad provides the descent relationship for other siblings. So this is called 3-generational pedigree. And in the 3-generational pedigree, you're basically trying to, depending on the presentation that you're seeing in your proband, if there is any similarities of pertinent clinical presentation in the family and the extended family. So that's where it makes a difference, because if the mom and dad are related, so instead of one single, you get double. That means there is a kinship going on. And that automatically gives you a clue of some of the subset of disorders that, or the inheritance rather, that you can think about, and if that could be a reason for the clinical presentation. So just talking about it, purpose of the pedigree is to look for patterns in the family that may point to specific inheritance pattern. We can identify other features that may point to a specific syndrome. We can look for other individuals. So if a child, the proband has something, what are the chances of other siblings or future siblings to be at risk? So having said that, these are the different inheritance patterns: de novo, autosomal dominant, autosomal recessive, mitochondrial inheritance, and X-linked. And we're going to go through each of them and the relevance of each of them. De novo, that means there is a variant that is not seen in either of the parents. And can that be a disease presentation or not? It's very important because, we talked about the chromosome earlier in the talk, right? Now, chromosomal microarray is a test where you stretch out the chromosome and you look if there are pieces of chromosome that are missing, that's called deletion, or sitting on top of each other, that's called duplication. Now, not so much duplication. In some instance it can, but deletion, that means like, a copy of the gene is missing, because chromosomes can have one or multiple genes, and it does have what we now don't call anymore junk DNA, because there is literature out there that the non-coding DNA is also important. So if we do a chromosomal microarray for whatever clinical presentation where we are thinking there is something going on, especially with multi-organ system presentation, with developmental delay. So the chromosomal microarray is actually the first line of testing. And if you see a finding, a variant, whether it is a deletion or a duplication, is that important or not is actually determined when we can test even the parents. So then if the parents do not have the same deletion or duplication, that becomes clinically important and clinically significant. So in those aspects, if there are some specific genes that are in that region, it is important to go further and look at those genes. So the significance of de novo mutation is only that proband is affected. So the risk to future pregnancies, if the parents don't carry that change, is 0. Autosomal dominant, that means one of the parents has the disorder and the genetic change that is present is significant enough to cause disease in the siblings. Now, we talked about, we have 2 copies, right? So with each pregnancy, if it's an autosomal disorders, the parents have 2 alleles. So they can either pass this one or they can pass this one. So if the affected parent is passing on the disease allele, and that causes disease in the offspring, that is an autosomal dominant. So if the parent is passing on the non-disease causing, then that will not present as a disorder. So bottom line is that a parent with autosomal dominant disorder has 50% chance of passing on the disease allele with each pregnancy. And it affects males and females equally. Apart from Marfan's, younger learners can look up Huntington's too. Those are some of the examples. So when you draw a pedigree, as you see, that's the affected parent, and it is kind of affecting both males and females equally. Here, this offspring and this offspring did not get the disease allele, and that's the reason why these 2, 1, 5, and 8 are affected. And then we go down, this affected offspring, when has further offspring, there's 50% chance of inheritance. Going on to talking about autosomal recessive. Autosomal recessive conditions and most of the inborn errors are, and it can also affect in kinship or consanguinity when 2 partners are related. So basically, each parent may have the change and they are unaffected. But when both of them pass it on to their offspring, then with both the changes, the offspring has the disease. So in an autosomal recessive condition, with every pregnancy, there is 25% chance of passing on the condition, the alleles to present as a disease condition. There is 50% chance of passing on the disease allele, but you are not going to have the clinical presentation. You're just a carrier. So if you're a carrier, then that kind of like makes a difference in their subsequent offspring. So they have to kind of test their partner to see if they have similar changes in that gene to know whether their offspring are going to have the disease or not. And there is 25% chance of not having any disease or being unaffected. It affects males and females equally, but with the inheritance patterns is 25% chance of inheriting the disease if the parents are carriers for that specific genetic variants. The example out here is cystic fibrosis, but many inborn errors. And in fact, in the US, it is rare, but I can from memory talk about Indian descent child, 6 months of age, with a big belly, what we call the doll faces, coming in with lactic acidosis. Even before, as the lactic acidosis was getting taken care of by emergency room and then in the critical care, as the counselors had gone and started taking history, they found out that this was from a certain state within India that the parents were from, and the parents were actually first cousins. And just with those three information, that there is consanguinity, it was doll faces, and there was protuberant abdomen, that was enough for me as the on-call person to say that, okay, we are looking at GSD, that's glycogen storage disease. So that's how important family history and knowing what the presentation can help with. But if you go and in another instance, similar story, but when I went to examine the patient had coarse faces and little malformations that was visible. So then your differential diagnosis goes from a carbohydrate metabolism disorders to a complex molecule like mucopolysaccharidosis. So that's where kind of even from history standpoint, it is important to kind of family history plays an important role. That's what I was trying to get at. So this is an example of the autosomal recessive. Parents are carriers, and one of the offspring is a carrier, but the offspring's partner is also a carrier, and that's where there's 25% chance of getting the disease. And as you see, there are two, it affects males and females equally, and each of the disease-causing person can has a 50% chance, but here all the three offsprings were carriers of that disease. Going to talking a sex chromosome inheritance. Just like earlier slide, we talked about that females are typically XX and males are typically XY. Understanding X-linked inheritance, it has changed over time. Earlier, there was a strict divide between X-linked dominant and X-linked recessive. Since females, with one pathogenic change, usually were not supposed to have any clinical presentation, but in subsequent lectures, we'll talk about one of the, the junk DNA functions or the environmental factors that are epigenetic factors and X inactivation. And that's where kind of the earlier known thought of X-linked recessive, the X, if it's a female, they're not affected, is not true anymore. They may have milder symptoms, but they do have symptoms. Males may be mostly lethal, but females can show symptoms. So having thought about that, I can give you an example of a teenager, a 14-year-old budding volleyball player who was, every time she had a volleyball competition, and before the volleyball competition, if she had a long day at school and did not hydrate or eat herself, middle of a volleyball competition, needed to be rushed due to mental status changes. And in the second admission, I think we had just kind of part of our protocol at UPIT, we kind of check the ammonia, mental status changes. Let's check the ammonia, and her ammonia was high, and that's how we ultimately diagnosed her with OTC defect, which is an X-linked disorder. And then going back into family history, the males didn't survive, or they kind of died within a year of age. And that's how we came to the diagnosis. So we had to, which was kind of even with genetic testing, we did confirm that. And basically she had X inactivation to a milder form, but she did have, but with stressors like a long day at school, not eating. So when you don't eat for a prolonged period of time, your body kind of after utilizing your glucose stores and glycogen stores, go on to breaking down your protein. And that's what leads to urea formation, urea cycle defect, right? So that's how the presentation of mental status changes and high ammonia comes into being. So the knowing of different inheritance of different disorders and how that is going to should be in back of your mind is helpful with the clinical presentation. So as I said, more males are affected than females, and we talked about X inactivation, and carrier females always pass it down, but males who have it don't pass it down. They just pass it down to the females as carriers, okay? And X-linked dominant, where, it is passed down to males and females. So whoever has it, if the dad has it, that's passing down X. So both the females are affected. If it's mom, males, sons and daughters are affected. And this is basically a pedigree diagram of X-linked recessive. Males are affected, females are carrier. Males are affected, females are carrier. And while X-linked dominant, it is males and females are equally affected. Having said that, we come to mitochondria, as we had mentioned initially in the lecture. So mitochondria, as we said, it's the energy subunit of the cell, and it has its own DNA. So mitochondrial disorders, I feel, are the most fascinating subset of disorders and largely undiagnosed. And the defects can be in the mitochondrial DNA, which cause the mitochondrial deletion disorders, or the defects can be in the nuclear DNA, which cause the mitochondrial depletion disorders. The mitochondrial depletion disorders are autosomal recessive most of the time, and the mtDNA disorders, we all get our mitochondria from our moms. So this is a maternal inheritance subset. What makes mitochondrial disorders little bit more fascinating is the term called heteroplasmy. That means just because you get an affected mitochondria from your mom does not mean you and your siblings are going to get the same clinical presentation. And that's what heteroplasmy is, because with further division, the amount of affected mitochondria and amount of normal mitochondria is different in different siblings. And that brings me to another very interesting case. And so there was this teenager again who came to the ED seizing. And of course, they quickly did a gas and they found that there was base deficit and found out that there was lactic acidosis. But she was seizing, so they tried to kind of provide her with a lot of anti-epileptics, but the seizing wasn't actually resolving instantaneously. She was groggy, but she was seizing still. So that's where the call came. And moment I heard that there's lactic acidosis and seizing, I mean, my first instruction to the ED was start the kid on 10% dextrose, because the kid needs the lactic acidosis to be corrected slowly but surely, and that would help with the seizing. And lo and behold, within a couple of hours of getting, we usually in emergency protocol, we kind of provide 1.5 maintenance. So that's kind of the glucose infusion rate of around 8 or 10. We try to maintain that. Even in older, even though this is a neonatology concept, we try to do that even in older children and even adults for that matter, in inborn errors that present with lactic acidosis, because that's what helps in the clinical presentation than symptomatic treatment of the presentation. So in this case, that's what helped. And then further family history found out that, this, when I saw this kid, even though she was 14, she looked like a 10-year-old. She was pretty short. She had aspirations to become a nurse. And I was like, okay, let's kind of find out how we can best help while we try to find for the answers. And ended up letting me know that she was due to get growth hormone because her brother had got growth hormone. And then from family history, we came to know that they were being seen by endocrinologist, and the brother, who was a couple of years older, also had growth restrictions and was getting growth hormone. And it was over 6 or 8 months of growth hormone and not a blimp in the growth chart. And so that's where kind of my clues of trying to look for the mtDNA with Melas being high on my list of differential. We went and analyzed the mtDNA, and we found out that not only the child had it, this girl had it, her brother had it. With extended family history, came to know that mother had migraines, aunt had depression, maternal grandmother had early memory loss and had migraines and depression. So all that kind of came into play. And that was very helpful because we had to then coordinate with the endocrinologist on stopping the growth hormone treatments because it wouldn't help the underlying disease pathogenesis. And that's what gets us to subsequent conversations on genetic testing and ethics of genetic testing and counseling. This is basically a pedigree of the mitochondrial inheritance. As you see, if the male has got it, they don't pass it down. But if the female has it, they pass it down across generations. So talking about ethics of genetic testing and genetic counseling, the field of genetic testing has kind of like pretty much had a upward potential with technology. So from, say, 15, 20 years ago, when I was getting into the field, karyotype was kind of like the genetic test that people would go in. While I was training in it, we used to actually do analyze the karyotype. We would actually extract and try to look at each chromosome and try to figure out chromosomal anomalies with just the chromosomal microarray getting started. At the same time, with bioinformatics coming in, more so all the exons started also getting analyzed, and that's how the whole exome sequencing came into being. Last couple of years, not only the exons or the coding material, but the non-coding material, what we used to call earlier junk DNA, we don't anymore, because the non-coding material also has clinical importance, and that's where whole genome sequencing has found its foothold. I would say that apart from that, even certain number of genes are put in a panel based on clinical presentation, and those genetic panels are also now, and those are also based on the genome platform. It has kind of like gained popularity, which is helpful. But if you are looking at any syndrome or based on presentation, those are helpful. For biochemical defects or inborn errors, just having a change in a gene is not enough. Though it's getting rare, demonstrating that the protein, the functional analysis, like the defect, how that translates into the protein formation or lack of it, is more important in disease diagnosis and prognosis. So ethical pieces are important both in clinical care and in US from public health standpoint. With newborn screening happening, it is also important from public health standpoint. So now there is a lot of debate about whether whole genome sequencing should be part of the newborn screening. It is not about whether the technology is there to do a test. As my mentors in my field had mentioned to me when I first started my journey in this field, is like, genetic testing is like digging your nose. You be ready to what comes out and what you're going to do with it. So that has remained with me. So even though the technology is out there, I don't think we have a lot of clinical information in separating what is actually pathogenic or likely pathogenic versus a non-pathogenic or less likely pathogenic. And those are kind of the what you call it, the reports that you get when you do any kind of genetic testing, whether it is chromosomal microarray, gene testing, gene panel, whole exome, or whole genome. So yes, ordering a test is easy, but what are you going to do? And if you're ordering a test, you have to have the capacity to provide the right information about the results of the test. If you're not trained in genetics, you may not have that skill set to provide that, and that you're impacting patient care. And it can also, in US, it can be a malpractice situation. Now, apart from clinical care, there is also the public health standpoint. And from public health standpoint, like the newborn screening, right? It's a drop of blood, but you can actually isolate DNA from that and actually find out if some of the major conditions you have, whether you have those null mutations or not. So it's kind of like a debated aspect, how much of it you need to utilize for whole genome sequencing or not. So having said that, let's get into a case where that Dr. Gredanis has kindly asked us to share and have a conversation. It's about 11-year-old female who was seen first time in the teen clinic and presents with short stature, autistic-like features, abnormal gait. Initial genetic testing revealed one gene that was recessive for short stature. 11-year-old has been seen in an emergency room for fainting, and the ER staff was concerned that she was severely undernourished, concluding that starvation was the cause of the short stature. Girl is adopted with no other medical records. Before stating that the primary issue is starvation, would you recommend further genetic testing? What testing would you suggest? Now I will open up the floor for further discussion, what individuals feel, and have Dr. Gredanis provide us some insights and advice onto this case.
Dr. Gredanis, the floor is yours, and the participants.
Well, part of this was just to
questions.
point out the practicality of when do you do genetic testing, when do you not do genetic testing. The case comes from, as some of you know, one of my hobbies is music. I play piano and harp and used to be a church organist when I was a young fella. And unlike some of my other colleagues who play golf, I do other things, such as I provide consultations to lawyers, attorneys in malpractice cases. And so this was the case that I reviewed some time ago, where this young lady and her younger sister came in with severe growth and weight restrictions, very, very poor growth and weight. And her doctors that had taken care of her were just sort of said, well, we don't know what it is. We're not sure. They didn't have the girls were staying with adoptive parents, they had no biological, no pedigree, no biological background. They didn't know, other than the mother had some substance abuse problems. And so some of the doctors taking care of these two kids blamed it on fetal alcohol syndrome, of which there was no evidence. And so it went on and on. And so finally, this one young lady fainted, ended up in another state with low blood sugar, hypothermic, and they did a whole evaluation, and they concluded that the problem was the parents were not giving these kids enough nutrition, that this was a severe malnourishment problem. And they put the parents in jail, the adoptive parents. And then the parents said, well, no, this is a genetic problem, or it's fetal alcohol. And so I was asked by the attorneys attempting to provide some kind of help to the parents. Could it be genetic? Could there be a genetic problem instead of malnourishment? And the question comes in, it looks like it's obviously malnourishment. You're not feeding your kids enough for whatever reason. Why do parents abuse their children? That's another whole story. Some do. Some burn them. Some beat them. Some don't give them food. That's another whole story. But the question comes in, should you do a genetic evaluation? Originally, there was reluctance because it cost money. In America, who's going to pay for everything? Who should do this?
Good point.
But I was able to say, look, the parents are in jail, probably for the rest of their life. Don't we owe it to the parents and to these kids to see, could there be some rare genetic condition causing their extreme short stature and poor weight growth or not? Should we do a genetic evaluation? Should we not? And finally, the judge in the case agreed, okay, find a geneticist and do the evaluation. And so they did. And it turned out that they have this, there was, they did a testing for 358 genes for skeletal disorders at a major place, not Kalamazoo. And they found two changes in two different genes that were associated with autosomal recessive conditions, in which this one girl was a carrier, but no evidence of overt genetic disease. And we were able to go back in the case and say there's no genetic problem. This is a case of you're not feeding the children enough food over many years for whatever reason. Why some parents starve their children, we don't know. But the issue of genetics came up in this case. And so it became necessary from a legal and a defensive viewpoint to do a full genetic workup, even though the feeling was it probably isn't genetics. And so that comes up periodically. If you have a child with, say, short stature, mild, moderate, severe, do you have to do a genetic workup in each case, or when do you do that? And so that's where I sort of brought that case up, that this is a real case, a real issue, and the issue of, okay, endocrinology has weighed in. Should we get genetics to weigh in or not? And that often becomes the issue in terms of a full evaluation. Shouldn't we get genetics involved? So that's where that case came in.
Thank
Yeah,
you, Tom. It was
definitely.
a
I mean,
very-
this brings out,
Yeah, go ahead, Shibani.
yeah, this brings out like some very key points. So, genetic disorders are, these are rare disorders, right? So they're not like as frequent as any other common chronic illnesses. These are like 1 in 80,000, 100,000. So from clinical standpoint, definitely taking care of the common causes is much more important before you get on to thinking about genetics or doing a genetic testing. Don brings up an important point about the price of genetic tests. They are $1,000 and more, like in the US. If your insurance is not covering it, people, families are stuck with that bill, and they have collections just because somebody ordered something and that person's not there anymore, and it's basically the family's burden. And that's kind of like a key ethical issue too, from standpoint of like, if there is suspicion that there is child abuse, there is kind of like starvation happening, and we do that in younger kids all the time. We admit them for 5 days, 6 days, 7 days, whatever, and provide them the nutritional support and see if there is a weight gain. If there is weight gain, that means on a cellular level or even on a genetic level, nothing is going wrong. Once the body, a starving body, it kind of just like a starving child will absorb everything, because that is what is the key code, is to break down all nutrients for survival and growth and regeneration. So sometimes like we do kind of feel like, there is a little bit of a fanciness with genetics and genetic testing. More so, people may kind of steer towards that. But even in this case, I think like probably either a close outpatient monitoring or even inpatient kind of if the nutrition is making a difference, then unlikely it is a genetic test, disease causing short stature. And there are very few genetic diseases that cause short stature. Of course, these subset of folks did approach it by trying to cover every musculoskeletal system to help find the diagnosis. And that's where, when you look at a genetic test in two siblings and one has only something, another has nothing, but their commonality is both are in starvation kind of situation, that time the common things need to be evaluated and deciphered more in detail. That's just my humble opinion.
Now, if you have a situation where you don't have a good family history, this is a case that the kids are adopted, you have very little information about the biological mother, father, the true XXXY. You really have almost no information. Does that add to the weight of, well, maybe we should do a genetic, because maybe these parents who are probably gone we don't know really. We have very little history.
It shouldn't be the first line of evaluation. I would just suggest that. I think definitely whether there is a family history or not, and there may be like a good family pedigree available, and nobody, there isn't any pertinent family history to help the case. So family history can provide clues, but lack of it also does not, it should not be discounted. So that's where kind of medical judgment, clinical judgment, what is happening, what are the common causes, even if it is in the cases that I talked about, lactic acidosis, most of the lactic acidosis are secondary lactic acidosis. So even if it's a young kid, even like a 4-day-old that got me into the field, acidosis, you've got to find out the common causes, rule out the common causes. Of course, start your intervention as soon as you can, given your clinical suspicion, and then try to rule out the common causes. If the common causes are ruled out, that's the time you can delve into genetic testing, because we are born with our genes. At no point of time in our lifetime that's going to change. So whether you do genetic testing today or day after, the genetic information will not change. So I think for prudent utilization of medical resources, even though it's a fancy thing that everyone wants to order, because in US it's just a click of a button in electronic health record system, I think there is a lot of room for differential diagnosis, clinical judgment, just the thinking process of different pathogenesis that a younger learner should engage in prior to ordering any genetic test. And once you order genetic test, you need to find out what you're going to do with it and how you're going to counsel about it.
Well, and then in this particular case, it was a legal case. So you have parents in jail, and everybody in jail is innocent. There's nobody in a jail situation who is not, they're all innocent. And they yell and scream about how innocent they are. And then you have the issue of, well, how far do you go to prove, and particularly if you're dealing with a judge situation and there's a trial, where do you say no more testing? Or, well, the parents are saying, and in every case of child abuse I've evaluated, everybody's innocent. Nobody did anything. And so it gets to be a point of, as an expert, you come in and have to give the judge or jury or somebody an opinion of Where do you draw the line? Where do you say no? In this case, I said, do some testing. Parents are in jail. It looks like it's this, but because that will, with the testing coming back and all the other specialists involved, this will show this was a starvation case. And then you can, as the expert, back off and say, it's up to the jury. What do you do with parents who may be starving their children to death? That becomes a, what does the law say? But where do you draw the line of everybody's innocent? How far do you push to prove? And in a jury situation, both sides are pushing and pushing and pushing to make their point.
I understand that, and many of, like, for example, in this case, right, fetal alcohol syndrome, many of the known syndromes, they actually have established clinical criteria that any geneticist, and in some cases even developmental pediatricians, can actually go through those criteria. If you meet those criteria, going on to further genetic testing is warranted. If you don't meet the clinical criteria, in that case, genetic testing is not warranted. Of course, in this case, the judge providing a legal direction, that provides you with little leeway of whether or not you have a choice. But had the judge been provided all the pertinent information, then probably kind of like, because the test that you're talking about, it's a good $7,000, $10,000 test. So who footed the bill, right? So that's
right. I didn't ask that. And then the final thing on this case I'll say is you get the other side, where there were healthcare people involved in these kids, watching them over several years, and did nothing. Didn't do any testing. So what happens with them? And my view was, I'm not involved in that. I'm not answering that.
That's where
I'm not going there. Yes. What do you do when nobody steps in?
Yeah, that's where I think, the medical care, clinical care in this country needs to think about whether we are trying to do what is in the best interest of patients and our community and population at large, versus whether we are, generating enough RVUs to have the clinical enterprise thrive. So that's kind of the ethical question I'll leave the group to think about.
We are mandatory reporters. If you see something going on, even if you're wrong, but if you suspect there's a problem and nobody else is addressing it, from the child abuse perspective,
exactly,
you are mandatory to say something, even if you are wrong. That where it gets tricky is, what if your colleagues are going to get mad at you? What if you're in a small town and you're accusing your colleagues in a small town or a big town of malpractice, something, and you may be right, you may be wrong, but it gets complicated.
It does. At least in my experience, I think, the bigger the institution that I was part of, I felt like there was little tolerance of swerving away from what your lane is. But I think, the smaller places, it seems like, there is a little bit of comfort in trying to dabble into everything, which may or may not be in the best interest of patient or anyone else.
Thank you, both of you. It was a fascinating discussion. And so many points were brought out by this case. It was really very interesting. And Shibani, congratulations. This is such a tough subject, and you made it so interesting with your examples and simplification. And I enjoyed going back to my MBBS days, learning about genetics and chromosomes and autosomal dominant and recessive. But you really made it very interesting and very simplified. And we are definitely going to share the recorded link so that more and more people who could not join today will get the benefit of listening to this fantastic lecture and listening to you and Dr. Gredanis discuss this very, very important and very intricate ethical dilemma of the case. Thank you, both of you, for
Thank
a
you.
wonderful discussion. Prashant?
Thank
Have a
you.
good evening.
Thank you so much. It was really a nice discussion. Even my son was listening. He said that I know these things because he's in 12th standard.
Oh,
So,
very good. Very good.
so for him, this was a good thing. So thank you so much. Yeah.
Thank you.